Welcome everyone. So in this lecture, we will be discussing about a category of interstitial lung diseases that is labeled as IPAF, which stands for Interstitial Pneumonia with Autoimmune Features. So when we were reading about the classification of ILD, I told you that ILD could be divided into two broad categories that were unknown etiology and known etiology. So the ILDs with unknown etiology were known as IIPs, that was idiopathic interstitial pneumonia. And under known etiologies, you had various categories, out of which one important category was CTD ILD. So CTD ILD are those patients who have a known CTD, that is, they have a known connective tissue disease. They meet the diagnostic criteria for that connective tissue disease, and along with this, they also have an interstitial lung disease. So IPAF is basically a category of ILD that lies between these idiopathic diseases and CTD ILDs. So it lies somewhere in the center such that the patient has an ILD. The patient has an ILD, and along with the ILD, he has certain autoimmune features, which could be in the form of certain clinical symptoms like joint pain, arthritis, palmar telangiectasias, Raynaud's phenomena, etc. There could be certain clinical features or laboratory features or radiological features that suggest the presence of autoimmunity, but the patient does not meet the diagnostic criteria of a known CTD. So therefore, it's somewhere in the middle. One end of the spectrum are idiopathic interstitial pneumonias, where there is only ILD and no autoimmunity. On the other end, we had CTD ILDs, where there is ILD as well as an established connective tissue disease, and IPAF is somewhere in the middle, where there is ILD and there are certain features of autoimmunity, which could be clinical, laboratory, serological, or radiological, or histopathological, but it is not that strong to label the patient as having a CTD ILD. So it is an in-between category. What is the importance of this category, and why has this category been established over the last few years? The reason is, if we talk about IPAF and we compare it to patients with idiopathic interstitial pneumonias, so patients of IPAF actually have a better prognosis as compared to the idiopathic diseases. They have a better prognosis, and also they respond better to treatment. So till 5 years back, when this term IPAF was not coined and this category of ILDs did not exist, most of these patients were actually placed into the idiopathic interstitial pneumonia category. And this was wrong, because these patients actually fared better than the other patients and they responded to treatment better. So coming to the epidemiology of IPAF, then the mean age of IPAF presentation is usually in the late 50 to 60s. This is in between the age for IPF as compared to CTD ILD, where patients with CTD ILD usually come in the third to fourth decade. There is no gender predilection. We know that CTD ILDs are more common in females as compared to males, but when we talk about IPAF, here female is equals to male. Like I was telling you, most of these patients were actually previously labeled into the idiopathic interstitial pneumonia category. Therefore, if we correctly use the IPAF diagnostic criteria, then up to 20% of the patients who were initially placed in the IIP category would be relabeled or reclassified as having IPAF. So, with technological advancements, with more research, we are able to figure out more and more autoimmune antibodies that are responsible for ILDs. And once we have testing available for those antibodies, then these idiopathic interstitial pneumonia patients can be reclassified as having IPAF, that is interstitial pneumonia with autoimmune features. Also, up to 20% of these patients of IPAF, if they are followed up sequentially or longitudinally, then we will see that some of these patients actually go on to develop a connective tissue disease. So up to 20% of these patients can actually develop a CTD on follow-up, which suggests that this is a spectrum. ILD could be the first presentation of a CTD, and slowly and steadily the patient starts developing extrapulmonary manifestations of that CTD. Suggests that ILD can be the first presentation of a CTD. And therefore, in any patient who comes to you with an interstitial lung disease, you should always evaluate that patient thoroughly by taking good negative history for all autoimmune symptoms, by doing a head-to-toe examination to look for findings suggestive of autoimmunity, like presence of skin rashes, palmar telangiectasias, digital ulcers, digital fissuring, papules, nodules, rashes around the face. Do a good muscle examination, look for muscle power, joint examination, etc. And also run a battery of serological investigations to rule out autoimmunity. So this was about the epidemiology of IPAF. Coming to the diagnostic criteria of IPAF, which is the most important part of this lecture, then it has two components. One is an essential criteria. So the essential criteria includes that the patient should have an ILD as diagnosed by an HRCT scan and on PFT. So there should be an ILD. Along with an ILD, the patient should not have an established connective tissue disease. If he already has an established connective tissue disease, then that ILD is labeled as having CTD ILD. Therefore, it should not fulfill the criteria for a specific CTD. Third, the patient should not have any other etiology that can explain the ILD. So exclusion of other causes of ILD. For example, there should be no significant exposures. There should be no significant smoking, because then the smoking could explain the ILD. The patient should not be on any drugs that have a potential to cause ILD. So it could be exposures, drugs, smoking, etc. And apart from these three essential diagnostic criteria, the patient should have at least one feature from two of these three domains. So there are three domains, and the patient needs to fulfill at least two of the domains. And by fulfill, I mean the patient needs to have at least one feature from either two out of these three domains. So what are these three domains? So these are the three domains. You have a clinical domain, that is clinical features of autoimmunity. You have a serological domain, that is presence of autoantibodies that suggest autoimmunity. And third is the morphological domain, that is the presentation of the ILD either on radiology or on histopathology. So out of these three domains, the patient should fulfill at least two of the domains. So coming first to the clinical domain, so the symptoms that are included under the clinical domain include presence of digital fissuring, that is mechanics hands, digital tip ulceration that happens because of Raynaud's phenomenon and vasculitis, inflammatory arthritis with early morning stiffness of more than 60 minutes, presence of palmar telangiectasias, Raynaud's phenomena, digital edema, and rashes on the extensor surface, which are also known as Gottrin papules. So these are the features on clinical domain. Important thing to realize is what features are not present on the clinical domain, which include presence of dry eyes and dry mouth, alopecia, and mouth ulcers. So these are the few common autoimmunity symptoms that are seen in patients with SLE and Sjogren's, but these symptoms have not been placed under the clinical domain. This is what you need to remember. Coming next to the serological domain, this is a battery of autoantibodies. First, ANA. So an ANA titer of more than 1:320 is considered significant for the serological domain. So a titer of more than 1:320, this is present if the pattern on immunofluorescence is either diffuse, speckled, or homogeneous. So if a patient has diffuse, speckled, or homogeneous pattern, then the titer has to be more than 1:320. If the patient has a nucleolar pattern or a centromere pattern, then any titer of ANA is considered to be significant. Then any titer considered significant. So remember, nucleolar pattern and centromere pattern, any titer is significant. For all the other speckled, diffuse, homogeneous, a titer of greater than equal to 1:320 is considered to be significant. Then you have rheumatoid factor, that is more than twice the upper limit of normal. You have anti-CCPs, you have anti-dsDNA, Rho, La, anti-RNP, anti-SM, anti-topoisomerase, also known as anti-SCL70. Then you have certain anti-synthesis, tRNA synthesis antibodies like Jo1, PL7, PL12, EJ, you have anti-PMSCL, and you have anti-MDA5. Again, which are the antibodies that are not a part of it? So first of all, you don't have ANCA, or we can say anti-PR3 and anti-MPO. Then in the myositis antibodies, you don't have anti-MI2, you don't have anti-SRP, you don't have anti-Q. You also don't have anti-NXP or TIF. So these are the antibodies which are not a part of this. The reason these antibodies are not a part, because ILD is usually not a presentation when these antibodies are positive. For example, in myositis antibodies like MI2, NXP, TIF, it's usually the patient only has myositis and there is no ILD. Also in anti-SRP antibody positive myositis, you have necrotizing myositis, but you do not have interstitial lung disease. Coming to ANCAs, ANCAs are usually associated with vasculitis. Anti-MPO antibody can be associated with ILD, but it's uncommon and therefore it is not considered part of this serological domain. Next, coming to the morphological domain. So under morphological domain, it could be radiological features, or it could be histopathological features, or it could be presence of multi-compartment involvement. So first, coming to the radiological features. So if the patient has NSIP, OP, NSIP with OP overlap, or LIP, presence of any of these patterns, NSIP, OP and LIP pattern, suggest that the patient is meeting the morphological domain. Again, important thing to note is that UIP pattern is not a part of this morphological domain. UIP pattern is not a part of this domain. So if the patient has NSIP, OP or LIP pattern, then the patient is meeting the criteria for morphological domain. But if he has UIP pattern, he is not meeting the criteria for a morphological domain. Similarly, on histopathology, you can have NSIP, OP, NSIP, LIP, or you can have presence of lymphoid aggregates, which suggest a lot of lymphocytic inflammation, suggestive of autoimmunity. And last is the presence of multi-compartment involvement. So whenever there is a CTD, or CT-like symptoms, then autoimmunity usually affects multiple parts of the lung. It can affect the airways, it can affect the parenchyma, it can affect the pleura, the pericardium, as well as the vasculature. So whenever more than one compartments are involved, you start thinking towards autoimmunity. Therefore, if the patient has unexplained pleural effusion or pericardial effusion, if the patient has unexplained airway disease in the form of bronchiolitis or obstruction on the PFT, or if the patient has unexplained pulmonary hypertension suggestive of type 1 PH, in all these conditions, you think that there is some autoimmunity going on because multiple compartments of the lung are involved. So if any of these three criteria are met, then the patient is set to meet the morphological domain. And if out of clinical, serological and morphological, the patient meets any two of the domains, then the patient is said to have IPAF. So just one thing I want to explain further is about UIP pattern. So like I told you, UIP pattern is not a part of the morphological domain for the diagnosis of IPAF. This does not mean that IPAF patients cannot have UIP pattern on CT. For example, if the patient has inflammatory arthritis, plus the patient has RF antibody positive, and along with this the patient has an UIP pattern ILD. So if you see this patient is meeting the clinical domain, he is meeting the serological domain, but he is not meeting the morphological domain. Because he is meeting 2 out of 3, this patient is said to have IPAF with UIP pattern. So although UIP pattern is not a part of the criteria, patients with IPAF can have UIP pattern if they are meeting the other clinical and serological domain criteria. So remember the list of antibodies and the clinical domains. This highlights that for any patient who is coming to you with an ILD, any patient with an unexplained ILD, where there is no apparent etiology that can be ascertained from history and examination, you're supposed to look at these clinical features in the patient. You are supposed to order these serological tests wherever relevant, and on your imaging, you're supposed to look for these patterns which will give you clues that the patient might be having an underlying autoimmunity and can be diagnosed as having an IPAF. So you look for these features. Serology. So whenever you are reading your CT scans for ILD patients, do not just focus that whether or not the patient has an ILD, and do not just focus whether or not there is a particular pattern present. So apart from recognizing the pattern on HRCT, along with this, always look for extra features that help you give you clues, like whether there is any pleural thickening, there is any pleural effusion, there is any pericardial thickening, pericardial effusion, whether the pulmonary artery is dilated such of PAH, or whether the patient is having an airway disease, which would be shown by the presence of air trapping, centrilobular nodules, or if the patient is having a dilated esophagus, that might represent the presence of systemic sclerosis like symptoms. So always look for these other findings apart from focusing on the main finding of interstitial lung disease on an HRCT. So these are the few images of the clinical findings that can be seen. So here you can see digital fissuring, which is also known as mechanic's hands. Then you can have digital ulcers. These are usually seen in patients who have severe Raynaud's phenomena. Then you can have palmar telangiectasias. You can have unexplained digital edema, and you can have these rashes on the extensor surfaces known as Gottron's papules. So all of these are clinical features of IPAF. Coming to the prognosis of IPAF, then as I told you, IPAF patients fare better as compared to the idiopathic interstitial pneumonia patients. So if you make a spectrum of IIP, IPAF and CTD ILD, then CTD ILD patients have the best prognosis. Idiopathic interstitial patients have the worst prognosis, and IPAF is in between. If we break down IPAF depending upon the histopathology or the radiology pattern, then you can have UIP IPAF and you can have non-UIP IPAF. So again, non-UIP IPAF will have a better prognosis as compared to UIP IPAF, but UIP IPAF will have a better prognosis as compared to IPF, that is idiopathic pulmonary fibrosis. So if there is any autoimmunity, the possibility of the patient responding to immunosuppression is actually high, and therefore it's important to recognize patients as having IPAF even if there is a UIP pattern on histopathology or on radiology. So what I'm trying to convey here is that suppose a patient is coming to you with clinical symptoms of ILD, you do an HRCT, and on HRCT you're finding an UIP pattern. So do not label all of these patients as having IPF. Do not do this. You have to investigate these patients for alternative etiologies for that pattern, and one of those etiologies is the presence of autoimmunity. Therefore, we have to run serological tests and also evaluate for clinical symptoms and check if the patient meets the criteria for IPAF. If it does, then this patient can be treated with steroids and other immunosuppressive drugs, as opposed to IPF patients where immunosuppression is not to be used because of the higher risk of mortality. So this is the importance of understanding this category of ILDs, that is IPAF. Also, in our lecture on IPF, if you remember the diagnostic algorithm for IPF, the first step is to always rule out other etiologies for the ILD, which includes doing a serological testing. So this is a Kaplan-Meier curve that is again showing that patients with IPAF fare better as compared to IIPs, and CTD ILDs have the best prognosis. Coming to the treatment. So when we talk about the treatment of IPAF, there are no large-scale randomized controlled trials that have included patients with IPAF and studied what drugs work better. Most of the evidence that we have on IPAF comes from observational studies and has been extrapolated from CTD ILDs. So the treatment is similar to CTD ILDs, rather on the same lines, where we use immunosuppressive drugs. So the patients are initially started on steroids, which could vary from 0.5 to 0.75 mg per kg per day, and it is usually tapered over 4 to 6 months. And along with this, the patients are started on a second-line immunosuppressive, that is a steroid-sparing agent. And the options that you have are MMF, you have azathioprine, you have rituximab, and you also have cyclophosphamide. So this is about the treatment of IPAF, mostly similar to the lines of CTD ILD management. Rather, there is another school of thought. What some authors suggest is that patients of IPAF can also be categorized depending upon what clinical domain and what serological domain the patient is fulfilling. So IPAF can also be divided into 4 major categories depending upon what serology and what clinical domains are present. This could be an arthritis type. So these patients will usually have RF or anti-CCP positivity along with presence of arthritis. Then you can have a Sjogren's type. The patient will have dry eyes, dry mouth, and the patient will have SSA and SSB positivity. Then you can have a systemic sclerosis type, where the patients may be having Raynaud's phenomena, digital ulcers, anti-SCL70 positive, anti-centromere antibody positive, and you can have a myositis type, where the patient will have a tRNA synthesis antibody positivity. So IPAF can also be divided depending what is the most similar kind of a CTD that it represents, and treatment could then be along these lines. So the treatment could be along these lines. So this is all about IPAF, that is interstitial pneumonia with autoimmune features. Always consider this diagnosis whenever a patient of interstitial lung disease is coming to you in your OPDs. Thank you.